Good morning and good afternoon. My name is Luca Roberti. I am OSA patient and patient advocate for Italian Sleep Apnea Patient Association. Today, during this webinar, we are going to talk about a topic very dear to patients, possible new therapy for sleep apnea. Today's expert is Professor Atul Malhotra, whom I thank for is available even on the public holiday. And Professor Malhotra is the Director of Research for Pulmonary, Critical Care, Sleep Medicine and Physiology at the University of California, San Diego Medical School. We will talk about to us about the SURMOUNT study that has just completed phase 3. In this webinar, we have also joined the force with Monica Mallampalli from ASAP. I leave the floor to Monica. Please, Monica.
Thanks, Luca. Thanks for having me here. Hi, everyone. My name is Monica Mallampalli, and I'm the Executive Director of the Alliance of Sleep Apnea Partners. We are a US-based nonprofit patient-oriented advocacy group. Our mission is to promote and advocate for screening, diagnosis, treatment, and management for optimal health of those who suffer from sleep apnea. You can learn more about us by visiting apneapartners.org. We are also active on social media, including Facebook, LinkedIn, Twitter, and Instagram. So please follow us there. Again, thanking Luca Roberti for inviting me to be a co-moderator today and providing me this opportunity to listen and interact with Dr. Malhotra. So I just want to say a couple of things about these new innovation that is happening in the sleep medicine space. These are exciting times for the sleep apnea community, but I believe many patients are still not aware of all these innovations that are happening. So I think one of the reasons to have Dr. Malhotra is to, again, directly hear from him what this means for sleep apnea patients. So the innovations that are happening right now that are currently on the horizon are these new medications for treating sleep apnea. At ASAP, we support innovation because we believe that patients need options for treatment and to manage their sleep apnea. At the same time, we need these treatments to be safe and effective. We do not believe one size fits all, hence we support right treatments for the right patients. And that also allows us to look forward to a future where there is a personalized approach to treatments. So having said that, I will pass this on to Luca, and I look forward to hearing more from Dr. Malhotra.
Yeah, Professor Malhotra, we share the presentation.
Can you see on the screen?
Yeah.
Okay, should I go ahead?
Yeah.
Okay, thanks very much, everybody, for having me here. Thank you, Monica and Luca, for a very nice introduction. I'm looking forward to presenting the results of the SURMOUNT-OSA study. By way of disclosure, I was a paid consultant for Eli Lilly, who sponsored the study we're going to discuss. I'll talk a little bit about contributions from UC San Diego to obesity that are recent. Then I'll talk about the SURMOUNT-OSA trial design and talk about tirzepatide efficacy and adverse events. As a point of emphasis, we've estimated about 1 billion people worldwide with obstructive sleep apnea based on available data. This was published in the Lancet Respiratory Medicine about 5 years ago. With an apnea-hypopnea index greater than 5, that's sort of mild severity of sleep apnea, it's about 1 billion people worldwide that are affected with sleep apnea, which is a very common problem. Obesity is a major risk factor for sleep apnea, although clearly it's not the whole story. We published a meta-analysis quite recently regarding weight loss and improvement in sleep apnea. So on the x-axis here is changes in body weight. On the y-axis here is the changes in the apnea-hypopnea index. And the main point here is that as people lose weight, their apnea-hypopnea index improves, suggesting that weight loss might be an effective strategy. Whether the weight loss is achieved by lifestyle modifications, by medications, or by surgery, there's improvement in sleep apnea as a result of weight loss. We've published some work on this in terms of these incretin-based therapies, including tirzepatide, which is also known as Mounjaro or Zepbound. And the design of the study I'm about to present was also recently published in Contemporary Clinical Trials. So let's move on to the actual study design. This is for SURMOUNT-OSA. This was 2 different randomized double-blind placebo-controlled studies. Study 1 was patients not using CPAP, and study 2 were with patients who were using CPAP. So CPAP, continuous positive airway pressure, is the first-line treatment, but for patients who can't tolerate CPAP or refuse CPAP, study 1 looked at tirzepatide versus placebo. For patients who were using CPAP, we also looked at tirzepatide versus placebo. We looked at the maximum tolerated dose. There was escalation of the dose of tirzepatide. Tirzepatide is a weight loss drug which is approved in the United States for treatment of obesity as well as for treatment of diabetes. So we looked at people over 18 years of age with at least moderate sleep apnea based on an apnea-hypopnea index greater than 15. They all had obesity with a body mass index greater than 30. We excluded diabetes, and we excluded other sort of craniofacial abnormalities. So the primary objective here was to demonstrate that tirzepatide at a maximum tolerated dose of 10 or 15 milligrams once weekly is superior to placebo for changes in the apnea-hypopnea index from baseline to week 52. The secondary objectives were to look at tirzepatide versus placebo on the percent change in the apnea-hypopnea index, the number of participants who got more than 50% reduction in the apnea-hypopnea index, the number who got into a range where they may not need sleep apnea therapy anymore, and changes in what's called sleep-specific hypoxic burden, which is the area under the hypoxia curve. Other secondary outcomes included systolic blood pressure, body weight, and high-sensitivity C-reactive protein, which is a cardiovascular risk marker. As a point of emphasis, all of our secondary outcomes were pre-specified, and all were controlled for multiple comparisons. It wasn't just that we looked at hundreds of outcomes and published the ones we found interesting. We looked at everything and pre-specified our analyses, which is the most rigorous way to do it. We also looked at patient-reported outcomes. Often patient groups are appropriately concerned that we're making the numbers look better, but the patients don't feel better. So we're very careful to look at the PROMIS score for sleep-related impairment in terms of daytime function and sleep disturbance in terms of nighttime function. There's 2 different types of analyses here. There's an efficacy analysis, and which is called a modified intention to treat analysis. Not everybody is included in both analyses for very subtle reasons, but as I'll show you, the results are basically the same, so I wouldn't make too much of this distinction. The efficacy analysis is patients on drug. The modified intention to treat are patients randomized to receive the drug. So study 1, as I mentioned, is not on CPAP. Study 2 is on CPAP. We looked at 234 patients in study 1, 235 patients in study 2, and the vast majority did complete the studies. The placebo groups had some dropouts because of lack of efficacy. Not everybody continued, but basically it was a well-done study. We look at study discontinuation for adverse events. They were relatively rare. There were some subjects in the placebo group that withdrew, again, probably because of lack of efficacy. If you look at the demographic factors, these were on average 48 years old, sort of middle age, which is what we see in the sleep clinic. It was about 33% females, and that's important because many weight loss studies are predominantly women, because that's who shows up in bariatric clinics, even though sleep apnea is a male predominant disease. It turns out women lose more weight than do men with these GLP-1 receptor agonists with these kinds of medications. And so that gender balance is important, and we made a point of having 30% women. We also had good diversity in terms of racial and ethnic makeup. In terms of baseline clinical characteristics, they were quite obese. Body mass index at 39 is considered what's called class 2 obesity. 40 used to be the threshold we called morbid obesity. Now that's called class 3 obesity. And there was no diabetes, as I mentioned. In terms of other clinical characteristics, they had pretty severe sleep apnea, an apnea-hypopnea index of 51.5 or 50 in study 2. And there were relatively mild sleepiness in terms of the Epworth sleepiness score. So primary objective was to demonstrate that tirzepatide once weekly was superior to placebo for change in the apnea-hypopnea index. And the baseline characteristics of retention participants during the study reassure results are similar to clinical practice. So I'll now present the results of the SURMOUNT-OSA study. And as some of you know, this was recently published in the New England Journal of Medicine. I published lots of papers, but this one was actually quite special. I was quite excited by this result. If you look at the change in the apnea-hypopnea index, on the left is study 1, that is not on CPAP. Study 2 are the CPAP patients. You can see a marked improvement in the apnea-hypopnea index, more than 50% reduction on average in both the efficacy analysis as well as in the modified intention to treat. Similar results with study 2, about a 30-point improvement in the apnea-hypopnea index, a marker of sleep apnea severity, in both the efficacy analysis and the modified intention to treat. Again, these results between the two analyses are very similar, so I wouldn't make much of a distinction there. In terms of key secondary outcomes, we looked at the percent change in the apnea-hypopnea index. You can see about a 55% improvement in study 1 in the apnea-hypopnea index, a marker of sleep apnea severity, and about a 63% improvement in study 2 as a marker of sleep apnea severity. When we looked at the percent with a more than 50% reduction in the apnea-hypopnea index, it was quite good. In study 1, it was about 61%. In study 2, about 72%, and very similar results with the efficacy analysis shown there. These are patients who you might consider cured of their sleep apnea. They had an apnea-hypopnea index less than 5, which is considered normal, or between 5 and 14 without daytime sleepiness. And so these patients may not need CPAP treatment, although there's some debate about how much to treat mild sleep apnea. But in that context, we saw about 40% of patients in study 1, about 50% of patients in study 2 who met criteria that you might consider no longer need CPAP treatment. If you looked at the shift in the apnea-hypopnea index, let's focus on the tirzepatide group in study 1 and the tirzepatide group in study 2. You can see severe sleep apnea improving markedly with 52 weeks of treatment. Similarly, with moderate sleep apnea, you can see marked improvements with tirzepatide. Very similar pattern in study 2, with severe sleep apnea getting much less in study 2, and moderate sleep apnea also much less in study 2. If we look at the hypoxic burden, that's the area under the hypoxia curve. It's the amount of low oxygen that your body's seeing. That's also markedly improved. This is a marker of cardiovascular risk, and that gets markedly better with tirzepatide therapy compared to placebo in both study 1 and in study 2. When we looked at changes in body weight, we saw about an 18% improvement in body weight, about a 20% improvement in study 2 in terms of changes in body weight. To contextualize that, if you started out at 100 kilograms, a 20% weight loss would be about a 20 kilogram or about a 45-pound weight loss at 1 year, which is quite a marked effect. We looked at changes in high sensitivity C-reactive protein. This is a cardiovascular risk marker in both the efficacy analysis over here and the modified intent to treat analysis over there. In both study 1 and study 2, there are marked improvements in high sensitivity C-reactive protein as a marker of cardiovascular risk. You can see a marked improvement with tirzepatide therapy compared to placebo. If you look at systolic blood pressure, also marked improvements, about a 9.5 millimeter mercury improvement in systolic blood pressure in both study 1, about an 8 millimeter mercury improvement in study 2. Very similar results with the efficacy analysis as the modified intention to treat. If you look at diastolic blood pressure, this is not a pre-specified outcome, so I won't discuss it further, but it looks the same. If you look at the PROMIS scores, now these are patient-reported outcomes. We pooled the analyses, pre-specified for sleep-related impairment, that's daytime symptoms, and sleep disturbance score, that's nighttime symptoms, were markedly improved with tirzepatide therapy compared to placebo, both for daytime symptoms and nighttime symptoms. So patient-reported outcomes were better. So to summarize the efficacy results, tirzepatide demonstrates superior and clinically meaningful improvement of sleep disorder breathing compared to placebo. Tirzepatide demonstrates superior improvement of sleep-related functioning and quality of sleep compared to placebo. Tirzepatide demonstrates superior improvement in cardiovascular risk factors compared to placebo. And again, as a point of emphasis, all of the analyses were controlled for multiple comparisons and all the secondary outcomes were pre-specified, suggesting that these are robust findings. In terms of safety, there were some serious adverse events. They're actually more in the placebo than in the tirzepatide group, but serious adverse events are seen. Treatment emergent adverse events were very high in both groups, which is typical of a one-year clinical trial in this type of patient population. So there's no excess risk in tirzepatide with placebo in either of the groups. That's concerning. If you look at treatment emergent adverse events with more than 5% frequency, not surprisingly, the symptoms that are seen with tirzepatide are often gastrointestinal. That's consistent with clinical experience. Nausea, vomiting, diarrhea, these things are more common in tirzepatide than placebo. The good news is it tends to go away over time. So at 1 year, there are very few of these side effects anymore for patients who continue taking therapy. Very similar kind of thing in study 2, where you see nausea, vomiting, diarrhea more common with tirzepatide than with placebo. Adverse events of special interest. There's concern about pancreatitis with these medications. There were 2 cases in total in the whole trial of pancreatitis, both in the tirzepatide group. And I looked at these very carefully. I work in the intensive care units as well, so I know a lot about pancreatitis. Both of these cases were quite mild, and it's not even clear why they looked for pancreatitis. So sometimes people with nausea, vomiting, abdominal pain, doctors are more likely to check a amylase or lipase blood test. There may be something called ascertainment bias, where you tend to diagnose it more in patients who have those kinds of symptoms. Suffice it to say, I wasn't worried about these, having reviewed them very carefully with my intensive care medicine hat. So to summarize the safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with safety profile of tirzepatide and incretin-based therapies in people with obesity. So nausea, vomiting, these things are commonly seen. The most frequent adverse events are gastrointestinal, and were generally mild to moderate. Gastrointestinal adverse events are more frequent earlier in the study and tend to go away over time. There were 2 positively adjudicated cases of acute pancreatitis. Both were mild, both in the tirzepatide-treated patients. So key take-home messages. The tirzepatide maximum tolerated dose demonstrates superior and clinically meaningful improvement of obstructive sleep apnea-related sleep disorder breathing. Tirzepatide maximum tolerated dose demonstrates superior improvement of patient-reported quality of sleep and sleep-related functioning. Treatment with tirzepatide maximum tolerated dose translated to clinically meaningful improvements in obstructive sleep apnea and obesity-related cardiovascular risk factors. And the safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with the safety profile of tirzepatide and incretin-based therapies in people with obesity. And just a final slide here, we've a new treatment for sleep apnea, which is quite exciting. It adds to the existing therapies for sleep apnea. Treating both obesity and sleep apnea is still the standard of care. Just giving people CPAP and ignoring their body weight is not a good idea. Diet, exercise, and sleep are the 3 pillars of health. Existing obstructive sleep apnea therapies work well. We didn't compare CPAP to tirzepatide, and so it's not that tirzepatide is better or worse than CPAP. It seems it's an extra therapy, but not a replacement. And these academic industry partnerships work well. So we just had a editorial in the Lancet Respiratory Medicine saying that CPAP is here to stay, because many people look at the results and say, well, we don't need CPAP anymore, and that's not the message here. The message is that we have a new treatment for sleep apnea that looks to be effective to complement our existing therapies. So I'll stop there. I'd like to thank you all for your attention. I'd like to thank the organizers for inviting me. I'd be happy to take any questions.
Perfect. Thanks a lot, Professor Malhotra. And we have no question for the audience, but I have just a couple of questions. One question directly about the safety, because it's very important for us to understand the safety and the adverse event. I have one question about the dossier for the submission of the market application to the FDA is already been started, and if rated positively in the second half of 2025, it could be prescribable in the US, and subsequently we wait for the submission of European Medicine Agency, which obviously will happen later. What about you?
Yeah, so we did submit to the Food and Drug Administration on June 21st. We're waiting to hear back from them about whether there'd be an approval for treatment of obstructive sleep apnea with obesity using tirzepatide as a treatment. And they gave us fast track designation, so we should hear something soon. And the hope is that there'll be approval within 2024. However, it's important to know that tirzepatide is already approved for diabetes and for people with obesity, that is a body mass index over 30 kilograms per meter squared. So in theory, at least, the approval for sleep apnea may not change the idea that obesity is still there. Everybody in the study I just showed had a body mass index over 30. So having an on-label indication for sleep apnea will be important, but we can still use the medication for obesity with or without sleep apnea. That's FDA approved already.
Perfect. Thank you. Monica, you have some questions?
I do. First of all, thank you for those for the presentation. Those results are really stunning here. And you're right. It's pretty exciting to see that. I just had a question. Have you thought of some additional analysis, just looking at even just male and females and looking at their drop in AHI, or have you done that? And just even age-based to see if are there truly differences? You did say the obesity, women tend to lose more weight, although you only had 33%, considering, OSA is more frequent, common in men. So I'm just curious about that. Have you thought about it that way and looked at some of the analysis?
Yeah, there are a million different analyses that people want us to do that we want to do. What we're very careful, at least for now, was to pre-specify all of our analyses and control all of them for multiple comparisons. We wanted to do it that way because New England Journal of Medicine insisted on it, saying that you have to control for every comparison you make. And same with the FDA. They want everything pre-specified and controlled for multiple comparisons. So all those are interesting analyses. When we do or don't get approval, we'll start looking at some of those things that are exploratory. We do know from other literature that women lose more weight than do men with these GLP-1 receptor agonists. And why that's the case isn't entirely clear. Some people think it's just a matter of body size and the pharmacology of the drug. You just gave more drug to men that they also lose more weight, but that's a theory. Nobody knows. It is important to think about how this study compares to other tirzepatide studies. Yastrebov had a paper in New England Journal of Medicine, the SURMOUNT-1 study, where they saw about 21% weight loss. We saw 18 to 20% weight loss, depending which study arm, which is similar but not the same. And so it could be that because there are more women in SURMOUNT-1 than there were in SURMOUNT-OSA, the study I just showed, that they had more weight loss, because we expect that with tirzepatide. It could also be that their follow-up was just over 70 weeks. This was 52 weeks. It could be that the longer duration of follow-up would allow more weight loss, because there's ongoing progressive weight loss over time. But the other point to make is that people with diabetes tend to lose less weight than people without diabetes with tirzepatide. The SURMOUNT-2 study was in the Lancet a few years ago that showed 13 to 14% weight loss rather than 21%. And so the fact that we excluded diabetics may have given more efficacy for tirzepatide, because there'd be less of that diabetes. So the short answer is I don't know. We haven't done those analyses yet, but we will.
That's great. Well, thank you so much. Luca, can I ask another question? You did, first of all, some of what when I was looking at your data, you saw much more, changes with the CPAP, the study 2 participants. I'm just curious about that. I mean, there was a washout period, if I'm correct, when I looked at your paper for a week. But do you think there is something that's being carried forward even with the long-term use of CPAP? And I liked what you said also in the end, so that it's all about the messaging to the patients too. to say that some of these people have adopted to CPAP treatment for a while, and just to give out the messaging is very critical, that perhaps this can also be used in combination, and not to give false hope to people that let's just drop CPAP and just think about this medication, although we're very specifically looking at obese patients. So again, can you explain some of that? What's the story with the CPAP group, or the group that had been on CPAP?
Yeah, so our hypothesis to begin with was based on the Chirinos study that was in the New England Journal of Medicine from the University of Pennsylvania, I think in 2014. Mm-hmm. And there they compared weight loss with CPAP or both, a combination. And it turned out that the combination was better than either one alone when you looked at insulin resistance and C-reactive protein and blood pressure and all this kind of thing. And I think the reason that's important is that it's been standard of care for quite some time to not treat either obesity or sleep apnea, but to treat both. I think treating both is important. So the new data with tirzepatide don't change the existing standard of care. What they do is give us a better treatment for obesity than diet and exercise. And what I often say is, if diet and exercise were highly effective, I'd be thinner, because I'm trying myself to lose weight. It's not easy.
Yeah.
But that's the argument, is that treating both sleep apnea and obesity is better than treating either one alone. So we did see some improvements in secondary outcomes that looked to be a bit more in the study 2 that were the CPAP-treated patients. You're quite right. They were off CPAP when they had the assessments done, because it'd be meaningless to study the apnea-hypopnea index on CPAP, because we know the CPAP works. It wasn't to look at whether CPAP was eliminating sleep apnea, to see whether tirzepatide was improving the underlying disease. But what I believe clinically is that treating both sleep apnea and obesity is a good idea. If diet and exercise don't work, then we have tirzepatide as an option for improving weight loss. And just one other point of emphasis is comparative effectiveness. It means you compare two active therapies. If you compare CPAP with tirzepatide, you can then decide which one's better. We didn't do that. We looked at CPAP-treated patients, tirzepatide or placebo, and non-CPAP patients, tirzepatide or placebo. A different study would be to compare CPAP effect with tirzepatide effect, but we didn't do that, and I don't really want to do that. I want to treat the whole patient, treat both the obesity and the sleep apnea, not either one alone.
Okay. Well, thank you for that. Luca?
Yeah, no, for me it's okay, and we want to finish the webinar. Thanks again, Professor Atul Malhotra, and also Monica Mallampalli for this webinar. Thanks a lot again. We see in the future with the new, maybe good news. Thanks a lot again.
Thank you.
Thank you. Thank you, Luca. Thank you, Dr. Malhotra.
Bye.
Thank you. Bye-bye.